Hi, I'm Alexander Westphal. I'm an associate professor in the Division of Law and Psychiatry at Yale School of Medicine, and also an associate professor in the Yale Child Studies Center. And I have several roles. I do academic work, I also teach, and I do some clinical work. With respect to the clinical work, I oversee a group of people who have committed crimes, but have also been found not guilty by reason of insanity. Most of these people have committed very violent acts. They are people in the process of transitioning from a secure forensic hospital into the community. My job is to monitor their risk levels as they progress through this transition. While some of these people do have autism, most of them do not. A second ingredient of my clinical work is to serve as a psychiatrist for a group of people with autism and intellectual disability in a network of group homes. Some of these people can be very violent. Today, I'll discuss autism spectrum disorder and violence risk assessment. In a way, this is in the middle of these two aspects of my job. So the topic of autism and violence is a difficult and sensitive one. It's sensitive because the population with autism is a very vulnerable one already, and the very act of speaking about the topic, whatever the facts or the association, runs the risk of promoting negative stereotypes. Out of the gates, I will say that the sensational acts of violence that have been associated with autism in the press, including Sandy Hook and post hoc diagnoses of autism that have been applied to people who have committed massive sensational acts of violence against strangers, both by the press and by academics, have very little to do with what I'm talking about today. These events are so rare that they'll never be predictable. There's also a very common type of violence, an impulsive lashing out that is most common in those with autism and intellectual disability. This sort of aggression requires specialized programming to manage and is one of the most common and substantial tasks of people involved with caring for this population. This is a population for whom the risk factors are clearly identified and addressed by programming. So the violence literature has a controversial distinction between two types of violence. This distinction is, I think, very helpful to understanding the relationship between autism and violence. One type of violence associated with autism is reactive violence, or hostile, affective, defensive, hot-blooded, or impulsive violence. This is the kind of bread and butter violence that I was talking about before. It's often associated with people with autism and comorbid intellectual disability, and again, is a very common issue. So much so that there are even two drugs with specific indications for the treatment of aggression in autism. The other type of violence, proactive violence or instrumental, planned, premeditated, cold-blooded, or predatory violence, is the very rare violence that has been linked to autism in the news in several acts of mass violence. It is really important to remember that these are two types of violence and that they are completely different things when addressing the question of whether the violence rates are higher in autism than in the typical population. The answer to that question, whether violence rates are higher, is yes or no, depending on which type of violence you're talking about. So if you're talking about reactive violence, yes, it is a common problem in autism. If, on the other hand, you're talking about proactive violence, no, this is an incredibly rare thing, and the rates of it are no higher than in the typical population. So it's really important, I think, not to lump all violence in autism together. I think a bimodal model of violence in autism is necessary to ensure that the actions of several individuals with autism do not dictate the way in which society thinks about the many millions of people with autism who pose no risk for committing the acts of mass violence that have been associated with autism in some popular news stories. As we shift to talking about risk assessment, I'd ask that you keep the distinction between these two types of violence in mind. In a way, reactive violence is a known entity. It's a type of violence we need to program for in specialized environments. And proactive violence is, again, so rare that the hope of predicting it is unrealistic. So where does risk assessment fit into this? It's really intended, and it being risk assessment is really intended to address the question of what to do in a clinical context when someone with a history or behaviors that raise concerns for violence, including statements about violent intentions or interest in violent topics, stalking, and so on, comes across your clinical practice. So, and I'll get into that more in a moment, but back to the problem of sensationalization and association. Here is an example of what I'm talking about.
It's so interesting, Joe, when you look at these cases, the mental health aspects of it, you could list issues with this young man that clearly should be warning signs, but they always seem so clear in retrospect, don't they?
Well, there's no doubt about it. And you know, I looked at the Virginia Tech shooter. I look at this shooter. So many shooters like this are young males. In fact, before, of course, you don't want to generalize, but as soon as I heard about this shooting, I knew who it was. I knew it was a young, white male, probably from an affluent neighborhood, disconnected from society. It happens time and time again. And I think a lot of it has to do, again, most of it has to do with mental health. You have these people that are somewhere, I believe, probably on the autism scale. I don't know if that's the case here, but it happens more often than not. People that can walk around in society, that can function on college campuses, can even excel on college campuses, but are socially disconnected. I have a son who has Asperger's, who is loved by everybody in his family and who is wonderful, but it is for those that may not have a loving family and a support group and may be a bit further along on the autism, an extraordinarily frustrating, terrible challenge day in and day out. And so I do think, again, I don't know the specifics about this young man, but we see too many shooters in these type of tragedies bearing the same characteristics mentally. So that's why I feel the way I do about healthcare.
This is purely speculative. Nothing I've seen before or since indicates in any way that James Holmes has autism. But even more alarming to me than sensationalistic reporting is sensationalism cloaked as science. For example, here's an abstract of an article that made it into print. And I'll read the abstract to you just to give you context. So in this article, we propose that Jeffrey Dahmer's homicidal behavior was intrinsically associated with autistic spectrum psychopathology, specifically Asperger disorder. The relationship of Asperger disorder to other psychopathology and to his homicidal behavior is explored. We discuss potential implications of the proposed model for the future study of the causes of sexual and homicidal crime. So on the basis of the conjectural views of the authors about a single person, we now have a scientific literature that associates autism with serial sexual homicide. So I've been discussing unusual situations. As I mentioned before, there's also the common bread and butter type of violence, the impulsive lashing out that is associated with intellectual disability. This sort of aggression requires specialized programming and is one of the most common and substantial tasks of people who care for people with autism. So this is a population for whom the risk factors are clearly identified and addressed by programming. Where risk assessment comes in is in the assessment and management of threats or warning behaviors made by people who have the capacity to plan violence and are not in settings where the level of oversight can prevent that. For example, when a kid says he's going to shoot someone at a school, or someone has been looking at how to build bombs online, things like that. So what is violence risk assessment? It's an attempt to estimate risk for violence, obviously. Clinicians frequently approach risk assessment on a case-by-case basis, tailoring their approach to the individual. This is sometimes described as a clinical judgment approach, and when done well, allows a clinician to create a detailed, dynamic, and qualitative portrait of the individual and their risk. In this approach, the clinician integrates what they know about the person's personality, symptoms, and environment with their understanding of the likely causes of violence. And that's a quote from the APA, American Psychiatric Association resource document. As a sole approach, it is limited. It is by definition idiosyncratic and is so not reproducible or transparent. It cannot be compared across time or populations. Clinical judgment approaches are contrasted with actuarial approaches. Actuarial approaches refer to a body of research that has identified risk factors across groups of subjects and uses the results to make predictions about the risk of individuals. The results are quantitative and so can be compared over time and compared over populations. As an example of an actuarial risk assessment tool is the Violence Risk Appraisal Guide, or the VRAG. There are various problems with actuarial approaches as the sole tool for risk assessment, including problems which arise from applying facts derived from aggregate data to individuals. One of the most fundamental problems with actuarial approaches is a consequence of the rarity of violence and extreme violence. In principle, the more rarely an event occurs, the more difficult it is to predict. The occasional true predictions get lost in the noise of false positives. This creates a clinical predicament. If a positive prediction of violence very likely represents a false positive, treating everyone who tests positive, for example, securing them in psychiatric hospitals, would be completely untenable and completely unreasonable. Furthermore, even if this approach were taken, it would inevitably miss people from lower risk categories who are going to act violently. Another approach, sometimes described as structured professional judgment, is intended to address the weaknesses of clinical judgment and actuarial approaches used in isolation by combining them into a predetermined interview structure that incorporates what is known about actuarial risk factors while also considering the specific dynamic aspects of this case. Some risk assessment instruments are designed to accomplish this. An example is the HCR, or Historical Clinical Risk 20 tool. There are a lot of risk assessment tools. Singh et al. Conducted a survey of 2,135 mental health professionals from 44 countries who conducted at least one risk assessment during their career. They found that 58% of risk assessments use some sort of structured instrument, and over 400 instruments were described. Half of these instruments were commercially available. The rest were developed for individual or within institution use. But as far as I know, no structured risk assessment tool exists for people with autism. So why did I go into all this detail about clinical approaches, actuarial tools, and all that stuff? Because I think there's a lot to be gleaned from the way in which risk assessment is approached in populations without autism. For a start, there are the many risk factors that have been identified by this work. Things like prior violence, risk-taking behavior, and the like, which heighten the risk of violence. We do know that mental illness can alter these sorts of risk factors. So reading from the APA resource document summarizing the ways in which mental illness modifies standard risk factors, the tendency for violent acts to be conducted by men is still present, but less strong. First offenses occur later, and the likelihood of acting violently does not fall off so rapidly with advancing age. The protective effects of stable relationships may also be less, particularly when someone's social and occupational functioning is poor. In other respects, however, the correlates of violent offending in the general population apply also to people who suffer from mental disorders. It seems perfectly reasonable to assume that, as with mental illness, autism may also modify conventional risk factors. In addition, it seems reasonable to assume that the diagnosis of autism may confer both protective factors and atypical or unexpected risk factors. I'll give a couple of examples in a minute. All of this, though, is another way of saying that we both need to reference the literature on risk assessment for populations without autism and think beyond this literature. The WHO, the US Centers for Disease Control, and others use a 4-factor social ecological model for organizing how to think about risk factors for both suffering from and inflicting violence. The overlapping rings in the model are intended to illustrate how factors at one level influence factors at another level. I think that this is a helpful model when thinking about risk factors for acting violently in autism. As I go through each of these levels, I want to emphasize that there must be a number of other factors. This is intended to illustrate rather than be exhaustive, and I would welcome your thoughts after the talk or with the contact info I'll show at the end. On an individual level, risk factors include standard ones identified in the neurotypical population, such as psychiatric comorbidities. Examples are intermittent explosive disorder and paranoia. Moving down the list, social isolation, a factor more directly related to autism, is very important, and it may include a number of ingredients which contribute to the risk. For example, social isolation can lead to a reduction in competing points of view and extreme thinking. A lack of scheduled activity can lead to all sorts of trouble. Social isolation can breed loneliness and misanthropy, and it can also exacerbate comorbid conditions like paranoia. Areas of interest are also very important and difficult. Intense interest in violent things like mass shootings, serial killers, terrorism, and guns are clearly alarming, but there are also less clear ones. For example, someone who amasses a huge collection of throwing stars. What do you do with that? Obsessive interest in military and law enforcement are also very common. Moving down, I discussed social cognitive deficits, things like theory of mind, empathy, things along those lines. Another factor can be hypersensitivity to an array of environmental stimuli. A worst case example of this is a violent reaction to a screaming baby, for example. And sexual frustration, difficulties navigating the complexities of initiating sexual relationships can also lead to aggressive behavior. Again, this is by no means an exhaustive list. So moving to the relationship level, you have family culture to consider, including extreme beliefs in the home as well as domestic violence. Another really important ingredient is caregiver mental health, as well as caregiver fatigue and resilience. And one of the biggest boots on the ground problems, which can be modified at a relational level, is lack of supervision online. On a community level, you have lack of adult programming, few social opportunities, few job opportunities, limited housing opportunities, as well as maladaptive internet communities drawing people's attention. So in terms of the internet content, you have search algorithms which steer people to very violent topics, graphic depictions of violence, including sexual violence, everywhere you look. You have video content, which models violence depersonalization. I have a colleague, Laurie Sperry, who speaks about a lot about the concern that video modeling, which is used very effectively for modeling pro-social behaviors as an intervention for autism, is in violent video games serving the very opposite purpose, creating scripts for violence. You have access to weapons designed for killing multiple people and gun loopholes which allow that. So how to address these multiple layers of risk? Going back to psychiatric comorbidities, you treat. And when treatment isn't available, at the very least, you recognize and program for the risk factor. And thinking about social isolation, social and behavioral interventions are critical. When you're talking about violent topics of interest, violent areas of interest, you need assessment, you need definition of what the kind of terrain of the interest is, and then you need intervention, you need redirection. And with respect to social cognitive deficits, there are numerous therapeutic approaches, and it's a very active area of research, this area, but it's also one where there's multiple defined approaches to draw upon. And finally, sexual frustrations. Sexual education programs like the Circles curriculum, as well as social opportunities, are key to addressing this. Moving to the family level of risk, for all of these, intervention at a family level is important. Family culture is a tough one when it promotes violence, and in more extreme circumstances, it may be important sometimes to remove the person with autism from the home. To address caregiver fatigue, respite and support are critical, and encouraging proactive, involved, thoughtful supervision when it comes to internet use is vital. And going back to the community level issues, the lack of adult programming, limited job opportunities, housing opportunities, and the lack of social outlets, all of these speak to the need for better adult services. Internet communities with extreme views are a real problem. And again, the first line of defense here is families and caregivers. This is not something to sit on, both from a risk reduction perspective and for the sake of protecting the individual from legal trouble. And then on the internet and societal level, you have search algorithms. And just to learn about this, for example, Google and the miseducation of Dylan Roof. So you Google the term Google and the miseducation of Dylan Roof, and you'll find all sorts of information on this and a very, very interesting rabbit hole to explore. With respect to depictions of violence and sexual violence in media of all forms, we need public pressure to address this. And so too with violent video game content. Public pressure is critical. And access to weapons, gun loopholes, public pressure legislation is, again, critical. Putting all of this together, you can see that there are multiple levels of intervention, ways to address the things I've been speaking about, ranging from individual interventions to societal changes. Going back to the purpose of my talk, what can you take from all of this? Bringing up a point I made earlier again, risk assessment in autism is largely for the population with higher functional levels. The types of people who may have made threats and acted aggressively before, but for whom programming designed for very aggressive people is not warranted and is going overboard. There are a variety of conventional risk factors that are relevant to autism, things like age, gender, substance use. But there are also risk factors that are much more relevant to people with autism than to neurotypical people. And there are a number of ways to address or mitigate these risk factors. And these were the things I've been talking about for the last few minutes. So that's it for me. I've included my email address in case you have more questions. I'm deeply grateful to Southern, to Eileen Farmer, to Michael, to Sam Tolkien for all of the work they've done and for including me in this and for working so hard to bring this together. I'm also grateful to Connecticut's Department of Mental Health and Addiction Services, a top-notch organization filled with really great people, as well as to Yale for supporting me. And I also wanted to acknowledge the Rumsey Cartier Foundation, which has supported my academic work for over a decade. Thank you all for attending and for your attention.